respected chairperson of the session and respected panelists and learned audience. Assalamu alaikum. I am Dr. Ashraf Rahman. I work in NICBT Dhaka, and my case today is drama and nightmares beyond successful PTMC. My case, a 30 years old married lady, normotensive non-diabetic, presented to us with palpitation and dyspnea, NOHA class 3. Her pulse was regular, BP was 90/65, and on precordial examination there was tapping apex beat, left pastern hip, loud S1 and loud P2, and there was an MDM over the apex. So we did her echo, and it shows there was severe MS. Valve area was 0.5 centimeter square, and LA appendage was free of thrombus, but there was spontaneous echo contrast in the LA. There was no MR. So we diagnosed her as a case of chronic rheumatic heart disease, severe MS. Valve area was 0.5 centimeter square, and she had mild TR with mild pulmonary hypertension, and Wilkins score was 8. So we planned for PTMC. We took the right femoral venous access and approached the PTMC, and we proceeded to the standard Inouye technique and did the septal puncture, and here the allography is seen by the broken bone needle. But we felt difficulty to enter the LV by the Inouye balloon. After repeated attempts at crossing the mitral valve by the standard Inouye technique, we failed. So we had to modify the plan, and we took 2 over-the-wire strategies to enter the LV. Our first strategy was to exchange the J-shaped wire and introducing the spring wire into the balloon. And the next strategy was removal of the Inouye balloon, keeping the spring wire into the LA, and taking the Mullen sheet over the wire. We tried several times with these 2 strategies, but we failed to enter into the LV through the mitral valve. So we again went back to the standard Inouye technique. We changed the shape of the J-shaped guiding stylet by the standard Inouye technique, and here you can see in the left side we could able to enter to the LV, but here if you look carefully, the Inouye balloon is hitting the lateral part of the left ventricle when it enters into the LV, and we inflated the balloon, but you can see the distal balloon is not inflating. So we pulled the balloon into the mitral valve further, and we then inflated the balloon. Then the distal and proximal, both the balloon are being inflated. Here the basic steps of PTMC is being completed. But if you look into the right side, after the close to the end of the procedure, the Inouye balloon is in the LA, but you can see the heart is not contracting that much. And at this very moment, the patient went to hypotension, and patient had cardiac arrest on the table, and we all rushed to the patient and started CPR, and the operator also tried to do the emergency pericardial synthesis, expecting that there might be some hemopericardium or pericardial tamponade. Here you can see the operator's hand, and patient was in arrest. We are doing the CPR, and there is auto transfusion was started. The bedside echo in the cath lab shows there is mild pericardial evasion giving rise to pericardial tamponade. So auto transfusion was going parallel to the CPR. You can see the hands of our team, someone giving ammo bag and someone doing the CPR, and there is pigtail catheter within the pericardial cavity. So auto transfusion is going on. We drawn about 300 ml of hemodialysis fluid from the pericardial space, and you can see in the right panel now the heart is more contracting and the cardiac shadow is decreasing. So there is improvement of the pericardial tamponade, and patient is being stabilized with our effort. So the complication of PTMC, you can see this is a Euro PCI textbook slide showing tamponade is not uncommon. It is 0.3 to 12% of the PTMC cases, and the main cause of The main cause of death in case of PTMC is the massive hemopericardium or the poor condition of the patient. Hemopericardium occurs in case of transseptal puncture or left ventricular perforation by the guide wires or the balloons. And it may occur in the less experienced operator. Unfavorable patient characteristics such as severe atrial enlargement or severe thoracic deformity, and incidence varies from 0.2 to 12%. So when to suspect hemopericardium? When there is sudden drop of blood pressure, and it should be confirmed by echocardiography or increase in the cardiac shadow, and patient should be treated by immediate pericardiocentesis, that means autotransfusion or reversal of the anticoagulant, and repeat PTMC can be attempted later. So patient was stabilized. We stabilized the patient in the cath lab. We waited for 30 minutes and did the echo repeatedly every 5 minutes. And then the patient was shifted to the CCU, and the bedside echo, the CCU showed there is still mild pericardial effusion, but patient was hemodynamically stable. We kept her in the CCU for about 3 more days, and when we did the bedside echo there. And the cause of difficulties to enter the LVR, critical MS, giant LA, low septal puncture, thickened septum. And this is the pre-discharge echo for the patient. The valve area is 1.3, so it was a successful PTMC. We did the 3D and strain echo of the patient, and valve area was 1.2 in the 3D echo. And echo strain shows there is an inferior lateral wall positive strain, the blue area in inferior lateral aspect, indicating this is the probable site of the injury. So my take-home message, sir, hemopericardium is not uncommon during PTMC. Incidence varies from 0.5 to 12%. It may be life-threatening and major cause of death during PTMC. May be detected even after successful PTMC. LV entry is a tricky part. Gentle manipulation and control application of force is mandatory. Sudden hypotension and increasing cardiac shadow are the telltale sign of pericardial tamponade. Early detection and immediate measure with a team effort can save a patient's life. Thank you. This is my team at NICBT, and I thank my operator, Dr. Abdul Mohammad sir, and his team. Thank you.